right. Hello, everyone. Thank you for attending today. Welcome, welcome. We apologize for the little bit of delay that we experienced, but we are all set and ready to go. So that being said, thank you for joining today's webinar, What You Should Know About Substance Use Policies in Tennessee. Now, this session is part of the Substance Misuse Prevention and Education Speaker Series, which is a quarterly webinar that is focused on advancing understanding and dialogue around substance misuse prevention, policy, and response. My name is Sharina Cathy, and I'm happy to serve as your host for today. The webinar is hosted by All for Knox, which is the joint substance misuse response initiative between the City of Knoxville and Knox County here in Tennessee. All for Knox coordinates prevention, treatment, harm reduction, and recovery efforts across our community to increase a spirit of collaboration as we all contribute to the substance-related epidemic or fight that we are all in. Now, we are pleased to be joined by our guest speaker, Elliot Pinsley, who will be sharing his experience, his expertise, and his insights on substance use policies here in our beloved state. Elliot serves as the Chief Executive Officer and President of the Behavioral Health Foundation, which is a data-driven nonprofit policy research center that is based in Nashville. They focus on mental health, addiction and overdose, criminal justice, children and teens, workforce issues, as well as social determinants. Now, before we continue, I'd like to review a few housekeeping items. I'm sure we're all very familiar with Zoom, perhaps more than we ever thought we would be. But a few items that I want to begin with is that today's presentation is being recorded. So following the webinar, all registered attendees will receive an email with information on how and where to access the recording using the email address that you registered with. So if that is incorrect, or if maybe you used the wrong email, please send an email to allforknox@knoxcounty.org with the correct information. Now, the presentation will last approximately 1 hour, and then there will be more time reserved after that for questions at the end. And questions will be addressed during the Q&A portion of the webinar in the order that they are received. For this session, you'll notice that all microphones and cameras have been disabled by default to minimize background noise. So you are encouraged to engage using the chat or the Q&A features that are located at the bottom of your Zoom screen. Please feel free to submit your questions or comments throughout the presentation, and then I'll be collecting the questions so that we can take care of them at the end. I also want to note that today's presentation is for informational purposes only, and it should not be considered individual legal advice. And then at the conclusion of the webinar, you'll be asked to complete a brief questionnaire to share your feedback. And the survey should open in a new tab in your browser. And it'll also be included in our follow-up email with information on how to access the recording. We truly do value your thoughts and would appreciate you taking a few minutes to let us know what you found helpful and how we can improve for our future sessions. So that being said, we're very glad that you're here and you're taking the time to join us in this conversation. With that, I'll turn it over to Elliot and he will get us started.
All right, thank you very much. I appreciate the opportunity to be here and talk with you all. And we've got there's a lot to cover here, and I did not get to put everything into the slides. I ran out of time, but there's far more than we could ever cover in this time. But I'm happy to answer questions, provide follow-up information afterwards, and so forth. So I hope you find this informative. I also don't really love just talking to a screen or a wall. I really do like interacting with folks. So while I was asked that we would hold most questions till the end, I still welcome folks to put it in the chat. I will try to be looking at it as we go. And if not, please keep any notes that you have. But if our host wants to interrupt me, you're more than welcome to ask about a question or for clarification. And I'll just proceed here. So we'll get started. There's a lot to talk about with substance use policy in Tennessee. It's a very exciting area, sometimes frightening area, just because of the implications of some of the policies. This is just a little bit more about me. I won't stick on this. Main thing is I don't have any conflicts of interest to report. This is meant to be a purely educational conversation. Just want to make sure everybody knows about the primary base of the most relevant substance use related policies that exist in Tennessee, primarily looking at state level policies. I know there may be some local Knoxville area policies that are in place, but that would not be the focus, and you all would be better experts on that than myself anyway. This is a little bit more about the Behavioral Health Foundation and what we do. I'm happy to share a copy of this at the end so everybody can get all the information, just so everybody's clear. Um, but let's get right into it. So why care about policies? I know policy is a big word, maybe even sounds like a bad word to some folks, but policy is at the center of pretty much everything you're going to be doing when it comes to delivering treatment, a lot of times prevention services, recovery programming, et cetera. And policy has a great deal of impact and influence on outcomes, on whether people get treatment, whether people overdose. You may have heard something called big P, little p. Big P usually means big P policy, capital P, meaning real, written, clear policies like laws and rules. But then there are also sometimes little p policies, which may not actually be a formal law or rule or other regulation, but it is a policy. It's something that shapes how something is done, delivered, um, received, however it may be. That is done maybe not by formal policy, informal. So that would be, for example, if a particular organization or provider decided, well, we're going to handle things this way, and we're gonna deny accepting this person for this reason. That would be a little p policy at their organization, unless it's written down, and then it could become a little different. But there may be big P policies that impact that or have something to do, and maybe says whether or not what that person or provider is doing is actually allowed or not under the law or rules. So just wanted to mention that in case people have heard about it. But it's really important to understand policies at play. If you're a provider, if you're providing any kind of overdose prevention services, you're administering naloxone, whatever it may be, just to know what you're allowed and not allowed to do to make sure that you don't get yourself into any trouble or your organization in any trouble. There is a lot of flexibility in a lot of areas, and in some places there is not. Um, and these policies very much play a real impact, often very directly, on the lives of people who use substances in Tennessee. And sometimes the consequences of not knowing the laws can be deadly. So we'll talk more about how that can be later on. But I also want to say that sometimes policies can help, other times not so much. And we obviously hope that the General Assembly is going to be enacting laws that are truly helpful to all Tennesseans. A lot of times they do apply the laws that are very helpful, and sometimes there are laws that put in place that unfortunately evidence shows are either unlikely to be helpful or maybe have even had a negative effect on people who use drugs. And and we've seen changes in overdose rates. It's harder to measure. We don't have a ton of data yet on a lot of the true impact in Tennessee on some of these policies we're going to be talking about, but there is a lot of data from other states that shows what we can expect generally when you replicate those kinds of policies. So this is meant to be practical. This is not meant to be an advocacy pitch. You may hear me say some things that I think are important that you might be interested in doing some advocacy around, but that's not the goal of today's talk. This is really meant to be informational and to give you a good baseline understanding of kind of where we are right now. So to really understand policy and know what it all means is you have to know who makes them and where they can come from, because it comes from different places. So obviously, the first thing people think of is laws, state laws. So we have this Tennessee General Assembly. It meets in a 2-year General Assembly. We're in the second year. It just started, and they can file bills in both years, but they're only normally debated during the regular legislative session, which generally occurs between January and approximately May. I say approximately May because last year, for example, they ended in April. They were in quite a hurry to get out of there. There was a big federal corruption case against the former Speaker of the House in Tennessee, and a lot of folks were subpoenaed, and they needed to be ready for that, and that caused a bit of a rush to shorten the session. The bills that are still remaining that were not did not fail on a vote last year are still they could still possibly be moved forward this year. And of course, anything that passed last year is no longer on the table. But a lot more bills are being filed. For those that are very interested in legislative advocacy, I was informed that I believe it was January 29th is the House filing deadline for bills this year. And I believe the following day, the 30th, would be for the Senate. Don't quote me on that, but that's what I had heard. And we'll see if that sticks. After that date, after those dates, any bills are not typically able to be filed without significant action that requires the leadership of the House and Senate to allow that. There's some procedural things that have to take place. So the General Assembly makes laws. They pass laws, and the governor can veto those laws. I believe the current governor's only vetoed one bill so far, which was relatively recent. But it is possible. However, it does require a two-thirds majority vote. And with a supermajority in power in the legislature, they could still pretty easily override the governor's veto if they all band together. So that hasn't been used very much. But I also want to be clear that the state budget is also approved and technically set by the state General Assembly. The governor puts out his budget proposal and then amends that and change it based on feedback from the legislature and others. But ultimately, it is the General Assembly that has the power to say yes or no on the final plan for expenditures for the year. That includes anything that may be cut or added. So, the Tennessee executive branch departments also play a huge role in policies and setting policies. So, and we're going to be focusing in, we're not talking about everyone that can create policies. We're really trying to focus in on substance use policy. So when we're looking at the executive branch, we of course mentioned the governor already, but under the governor are many different departments and divisions that can and often do create policies that relate to substance use and people who use drugs. So we start with one of the biggest entities there, which is the Department of Mental Health and Substance Abuse Services. And you may see them. I put abbreviations in case you see those later in the slides. I want you to know what they are. And they obviously have a lot of authority in this area since the state is decided through its executive branch that substance use related services and mental health services are going to be overseen and administered separately from other types of healthcare services. And that was to make sure that they remain prioritized, frankly. And it's been important to be sure that funding keeps going there and they don't get lost in the mix with other important, equally important physical and other healthcare issues. But sometimes, at least in the past, they had kind of played second fiddle and weren't getting anywhere near the amount of funding needed to be sufficient to meet the needs of Tennesseans. So we'll talk a little bit more about what kind of policies are involved from that department. But the Tennessee Department of Health also has some impact here, both in terms of overdose surveillance and just general state overdose response initiatives, and then especially for syringe service programs, as those are overseen and administered by the Tennessee Department of Health. TennCare also plays a major role. They're part of the Finance Administration Department of the state of Tennessee. And TennCare is, of course, the Medicaid agency for our state. And they contract with a set of 3 managed care organizations to cover and administer benefits to insured individuals who qualify for Medicaid. Just in case not everybody is aware, there is a common misconception among many folks that Medicaid or TennCare is for poor people in general. And that's frankly just not true. Being a poor adult does not qualify you for TennCare. You can qualify, though, if you meet income limits as well as being someone who is disabled, has a disability documented through Social Security Administration. You can get coverage as a parent or the children of those parents. And then also, as I mentioned, well, then you get Medicaid when you become an older adult. But a single adult who does not have enough income does not qualify for TennCare just based off of income. But TennCare provides a huge amount of the mental health and addiction services that are happening in Tennessee. And so they have all sorts of different programs, but they contract individually with certain providers. And they have that ability to say yes or no if they contract. They set the terms of those contracts. And then they have program descriptions for the different services that they will reimburse for. And then a manual that is provided to providers that has restrictions, rules, protocols, things they have to do, talks about where things like prior authorization may be required and so forth. I also mentioned a sampling. These are most of the main ones that I could immediately think of where there are more likely to be substance use related policies in place, but they can, of course, come in other departments too. But the Alcohol Beverage Commission absolutely sets policies and has rules on, how people are able to sell, package, and distribute alcohol in the state. So that's very important. Department of Children's Services administers they have a lot of rules, a lot of programs involving children who have been removed from parents due to substance use issues. Could be all or part of the reason they were removed. They also have children in their custody who have substance use issues and may need treatment and other services, as well as the parents of those children. So they're very much important to keep in mind. The Department of Correction also, unfortunately, in Tennessee, are corrections facilities, incarceration facilities, are the primary warehouse for people with mental health and addiction issues in the state of Tennessee. We do obviously have a lot of other treatment facilities, but there is a huge number of people with substance use disorder in Tennessee jails and prisons. They also have programs such as they offer medication for opioid use disorder treatment now in the Tennessee prison system in limited fashion, but it's showing some good results as I'm hearing so far. But they do play a very important role. The Health Facilities Commission, which licenses hospitals and other certain facilities, they have the ability to set some rules here for those that can provide substance use treatment. And I mentioned the Board and Department of Education just because of just how broad their reach is, both in terms of prevention education, as well as the number of children enrolled in Tennessee schools who have substance use issues. Now, we could go on to the Board of Regents, look at colleges, the same applies, but I wanted to give you examples so you understand just how many different entities have authority in some form or fashion to create policies that relate to substance use. Boards of health also. So boards of health are administered under the Tennessee Department of Health, but I wanted to mention it separately because it's a little different than the department itself setting these. These are boards that are run through that department, but each of these boards, I mentioned a lot, these are just some examples. There's tons. I didn't mean to pick and choose, but it could be, doctors, social workers. I mentioned LADACs, pharmacists, nurses, psychologists, go on and on. And those boards have the authority granted to them by the state General Assembly. So that's where the policy starts. There's something in the law that provides the rules, the authority to the boards to then create and enforce their own rules to make sure that the healthcare professionals they give licenses to are acting in accordance with those licenses, are not misusing or abusing any privilege that they are given. They're providing quality care to the extent they're able to ascertain, and that the licensure standards are adequate to protect the public of Tennessee. I also mentioned courts and law enforcement here. So this is a little different. They do have the ability to set their own policies for internal purposes, but they are really there to enforce the other policies that exist, the laws that are set by the Tennessee General Assembly. And potentially local government ordinances as well. So law enforcement is really, really important in this picture because of their enforcement abilities and the fact that there are major criminal penalties associated with a lot of substance use policies. And any discretion they choose to use can play a significant role. This is everything from direct on-the-ground law enforcement to decisions on whether to arrest somebody, and who to surveil or investigate, and then to the courts on who are we going to prosecute and how, what sentences are we going to apply. So there is some range in sentencing requirements on some charges and some discretion, and that absolutely plays a role in that impact people with substance use. disorder and people who use drugs or caught with drugs. And I mentioned a few of the entities involved, the Tennessee Bureau of Investigation, sheriffs, police, judges, and then Tennessee Corrections Institute. That is a statewide body that sets general policies, minimum standards for jails in Tennessee and provides training and other supportive services to sheriffs and jail administrators. Okay, so this slide is going to look at treatment. So obviously there's a little bit more to, when I say treatment, there's more to treatment than just treatment. There are other type of services that may not technically be considered treatment that can be funded through these providers and administer or these entities. But that's what I mean. This is more looking at the clinical and related continuum of services. So TennCare, we already mentioned it. They are using a combination of federal and state dollars for substance use disorder treatment coverage. And through their managed care organizations, where people may be members throughout the state, they receive services for substance use disorder. So they also create rules, like I mentioned, for the various programs that are offered under TennCare. The Department of Mental Health, they have the authority to set guidelines and rules for the providers that they have the authority to license. So this is everything from residential treatment providers to, well, on the mental health and addiction side. So we've got residential treatment. You have outpatient buprenorphine clinics. Those are generally OBOTs. You have OTPs or methadone programs. You've got all different levels of care. I won't mention all of them, but they have a set of licenses. They don't license recovery housing providers and don't directly regulate them, but there are some statutes that relate to that, which if we have time, I will get into later. But they absolutely have guidelines. They have rules and they are written, and there are periods of time where they can be subject to public comment, and individuals have the ability, or organizations have the ability to provide written and or oral comments. I always recommend written in addition to oral if you're going to be there in person, that they are then required to respond to, or at least acknowledge and consider to whatever degree they choose to in finalizing the rules. So for example, the Department of Mental Health, relatively recently, in the last couple of years, they put out new rules for both methadone clinic licensees and outpatient buprenorphine clinics. And those rules had some significant changes. Some were very positive for many folks, and some folks had some concerns about them. And this provided an opportunity. There was a public hearing to provide public comments. And then it took a little while for the next update, the final rule to come out. But I'll say I received it. We provided public comment from the Behavioral Health Foundation. And the Department of Mental Health did a really fantastic job at being responsive to comments. And they took a lot of them directly into account. Like there were changes made to these rules based off of not just mine, but other public comments in many areas. They didn't always make the changes. I'll say when I attempted the same through TennCare, they have generally said, thanks for your feedback. We're not changing anything. But that doesn't mean that you can't get changes to be made. So I wanted people who are interested in advocacy to understand that that is a key opportunity to pay attention to. And those rule hearings, off the top of my head, I believe that they are published on the Secretary of State's website. And I will confirm that if you're not able to figure out where it is. If anybody needs help finding that, I'm happy to share that info later. The Tennessee Behavioral Health Safety Net also is a core program under the Department of Mental Health. This is funding that is allocated, requested by the governor and allocated by the General Assembly for uninsured adults in Tennessee to receive a wide range of mental health and substance use related services, primarily treatment. There also is a behavioral health safety net fund for children that doesn't necessarily require a child be uninsured. Most children do end up getting qualified for insurance. So this does provide access. For example, there is an ability for kids who are not able to get case management through their primary insurance to potentially get case management services through Tennessee Behavioral Health Safety Net for children. And just a hot tip is, unless anything's really changed drastically in the last year that I'm not aware of, they have had plenty of the children's funds available. So if you know anybody who may benefit from that and otherwise can't qualify, you might want to look into that. Um, those funds are limited. They have been increasing a little bit over the last few years. There was an addition back in the special session that happened after the Covenant shooting that the governor had called. And that expansion was made permanent, I believe it was requested to be made permanent this year. And don't quote me on that. I have to double check. But those funds are very limited, and very often they do run out for the providers that are contracted to serve the uninsured people under that safety net. The federal government also provides significant funds to states that are called block grants, the SAMHSA block grants. And those block grants, they're broken out. There's a mental health side and there's a substance use side. And those grant funds are then distributed in Tennessee, the Tennessee Department of Mental Health, to various contracted entities who provide a range of services that are allowable under those block grants. So apologies for accidentally clicking. Those go to a lot of the addiction providers, the biggest providers, mostly nonprofits in the state, who then take those funds and use them for uninsured adults who don't qualify for services under insurance, and for some special projects that maybe are not directly related to insured services. Then they also provide a lot of other programs. They look at the recovery. They have the recovery navigators and the peer specialist certifications and various different councils and groups and special projects that help directly with mental health services. They fund prevention work, all sorts of things. So there's a wide range. We don't have anywhere near enough time to go into everything that they do, but Department of Mental Health is very much a primary place to look in terms of who sets rules, who writes policies, and who administers funding and programming related to substance use. Similar to how TennCare does it, there's private and other healthcare insurance companies that apply. That's where people get treatment, usually and very often through insurance, unless you're uninsured or it doesn't cover it. But there can be limits. There's uneligibility. They can have high copays. You can run out of sessions. All sorts of things can apply there. And TennCare has a little bit different that doesn't vary so much from managed care organization to managed care organization. And then, of course, the Tennessee General Assembly. So I already mentioned how they create laws that are then followed by these departments, and they provide authority to make rules. But they also create laws directly about how treatment can or can't be done that then help inform the various rules and guidelines set by other departments. So I thought this was important to mention as part of treatment, just because of its role and what the research is showing in terms of its importance in terms of opioid use disorder and reducing the risk of overdose and fatal overdose. But the term MOUD is something that's used very well across the nation in this space. It isn't as commonly used in Tennessee, so I just wanted people to hear it in case you hadn't already. Stands for medication or medications for opioid use disorder. It is a form of MAT. MAT is what I hear more commonly said here. Some people say MAT. I'm not a big fan of that, but if that's your flavor, then great. But MAT can be broader. For example, I talk below here about naltrexone being used for alcohol use disorder, right? So that is a form of medication-assisted treatment, but it is not MOUD because that would not be specifically for opioid use disorder if it's for someone with alcohol use disorder. So I hope that adds some clarity if anybody's wondered what those terms mean. There are 3 FDA-approved MOUD medications: methadone, buprenorphine, which can otherwise name brand originally that folks have known about is Suboxone, but it goes by all sorts of other names. You've got Subutex, you've got Sublocade, and so forth. So there's a lot of others. There's strips, there's tablets, there's long-acting injectables, and then naltrexone it's available orally in a generic form or in a long-acting injectable called Vivitrol. So while all three of these are FDA approved, again, I know this is meant to be focused on policy, but I'm here. I'm sharing some research findings, and I can provide sources on all of this. It's not included just because I didn't want to add too much depth. But methadone and buprenorphine are truly considered the gold standard by a number of sources, including the commissioners of health and Department of Mental Health in Tennessee, for the treatment of opioid use disorder. And while naltrexone can be used, recent reanalysis of the original trial data from when Vivitrol was originally approved has found that methadone and buprenorphine are at least 2 times more effective than naltrexone is when used for the treatment of opioid use disorder. So doesn't mean it may not play a role in the treatment, but if you have a choice between something that you know is going to have at least a twice better chance of helping someone be successful, that's usually what the research would point to trying. So obviously people may want to choose something else too. And the difference also between naltrexone and while some entities and individuals prefer it is not an opioid like methadone and buprenorphine are. And also naltrexone requires detox and withdrawal from opioids before you're able to start on it. So it's more in line with maybe the old school or traditional way of people getting into addiction treatment. Again, nothing wrong with that. It's just there are other ways that we can help people make sure that they can stay as safe as quickly as possible. There are many limitations on the use of buprenorphine in Tennessee that frankly do not apply to other medications, including other opioid narcotics. And this is interesting. There's an argument to be made that is discriminatory toward people with substance use disorder, but it is what it is. And they have been changing a little bit. Originally, Tennessee was one of 2 states that did not allow any type of nurse practitioners or physician's assistants, those mid-level providers, to prescribe or administer any form of buprenorphine. And that has changed some. Now they can, specifically psychiatric nurse practitioners and physician's assistants, but only in certain settings and with a lot of limitations. So they're not currently able to prescribe or administer what we call monoproduct. That would be buprenorphine without naloxone added. And that naloxone is added to theoretically help prevent potential misuse from anybody who might want to go that route, and diversion as well. And then you've got and it also there's issues with monoproduct because people argue it may be easier to misuse, but there are some safety concerns when using the combination product with naloxone with people who may be pregnant. And there are documented cases of people who have significant to severe allergies to the naloxone formulation. So it does need to be available to some people. And then there are also these long-acting injectable products that are being found more and more effective in a lot of situations, and that a lot of people are starting to want. And those are monoproduct that don't have naloxone. So we can't use those mid-level providers to help in providing those medications to individuals. There are patient limitations in place, and they vary based off of the settings. So the major settings are community mental health centers and FQHCs, which federally qualified health centers. So community mental health centers, FQHCs, and they have their own set of standards and limits. Then you have OBOTs. Those are the outpatient buprenorphine clinics that specialize in doing this type of treatment. And then you also have hospitals. And they have different sets of requirements for each in state law. So there are nurses and PAs can provide these medications to only a limited number based on which type of setting they're in. If they're not in one of those settings, they are not allowed to prescribe these medications. They also have differing requirements among those settings on supervision requirements as to the ratios of how many nurse practitioners or PAs a physician can supervise in these settings. So I wanted to point those policy issues out as they apply to treatment of buprenorphine and who can help provide it. Methadone clinics. Methadone clinics are a little bit unique in that methadone is largely not available as a prescribed medication outside of licensed methadone facilities, or OTPs as they're called through licensure. Licensed through the Department of Mental Health, again, as we mentioned. There are exceptions through short-term hospital situations, for example. But you can't generally just go get this medication at through a regular physician in a pharmacy like you can for buprenorphine with some limitations to it. Once someone prescribes buprenorphine to a certain number of patients, then they're no longer considered to be outside the rules of and what we call again the OBOT, the uh, outpatient buprenorphine treatment provider, and then they would need to get licensed if they reach a certain threshold of patients on those medications. Methadone take-home flexibilities are also available through relatively recent changes to federal law. And usually how that ends up working, then there can be some little p policies or potentially big p set by some of these methadone providers where they have certain rules where, depending on how well someone's doing or how long someone's been in methadone treatment, they will get increasing flexibility from them to, within this limit of the law, to come back every so often instead of every day to get their medication and to take it home. And that is allowed under federal law. Interesting about methadone clinics as opposed to other types of substance use treatment facilities like buprenorphine clinics, a formal certificate of need is required to open one, similar to when opening a new hospital. And that may be one of the barriers as to why we're not seeing a lot of methadone clinics accessible throughout the state. There are major deserts available. Now, to be fair, there's also significant stigma, and some local communities have gotten a bit up in arms not wanting methadone treatment available in their communities. But the certificate of need process may play a role. And in terms of anyone who may be interested in potentially offering mobile methadone treatment, the certificate of need process likely prevents a significant policy barrier to doing so. I just want to mention this. This is more little p policy than big P policy. But we did research a few years ago across the state of Tennessee via secret shopping study. And I've got a lot of information about the study for anybody interested. But we called pharmacies all across the state. We used random sampling methods and made sure we got representation from every county in the state. There's that at least that had a pharmacy. And these were our results. As you can see, more than half of all Tennessee pharmacies said they would not either not be able to or not willing to fill a new patient's buprenorphine prescription. And there were a variety of reasons provided for that. Some of which were just they don't want to do that. They don't want to treat that population. Some of them didn't want to get in trouble with the DEA. They had some misconceptions about enforcement, fears of getting investigated if they reach a certain threshold or being cut off by distributors that are just measuring how many overall opioids or controlled substance in general that they are ordering, and they just decide they're not going to do it. And a lot of these pharmacies also had limits on the number of patients that they were willing to serve through their pharmacy, which means new patients have to go somewhere else. And there weren't many that we asked that were able to tell us where else they might be able to go. So this is a really important issue because even if we can get someone to access a buprenorphine treatment program or someone who can prescribe that to them and help them with the induction phase, actually getting that medication may be a different story. And it's important to know they need some help and support to find a pharmacy that is open and friendly to them. Naloxone, obviously, a key part of the overdose prevention and substance use landscape and puzzle. There are a lot of laws, and I didn't name all of them directly. I mentioned one here at the end, which I'll talk about in a second. But a lot has changed in the last few years with naloxone. So of course, it's become over the counter. So it's more available than ever in terms of how you can purchase it. So anyone can go to a pharmacy and you can purchase it directly. You can get a prescription from a pharmacist. It used to be being standing order. I actually now believe there was a change last year. Again, please don't quote me on it. I didn't have time to double confirm. But I believe there was a change made that now pharmacists can directly prescribe naloxone without needing the standing order. But that's originally how it was done. They would have to have a pharmacist sign on to a standing order that was often written, typically written by the health commissioner or someone designated by the health commissioner, that allowed them to then, if you want a prescription, and they could decide whether to provide you one directly on the spot as opposed to having to go to another provider. But you can also get it by prescription. And there is even a law that requires that prescribers, in certain circumstances, when prescribing certain types and doses of opioids to patients, that they offer a what we call a co-prescription of naloxone to a patient. It's never required, and it should absolutely never be required that a patient fills that prescription. But we have heard stories that some patients have gone to pharmacies and either been told they need to fill their naloxone prescription or been pressured to do so. Again, that is a bit anecdotal. I don't know how widespread that practice is, but we have heard of examples happening in Tennessee. So there are different formulations. Before I mention that, there are various Tennessee laws that allow for, well, it's a set of Tennessee laws that allows for community members and first responders to distribute naloxone without fear of being sued if something goes wrong. And there also was a Tennessee law passed relatively recently, I believe it was 2 years ago, that allows for anybody to possess naloxone in school without fear of punishment. So schools in Tennessee are not allowed to take naloxone away from students or staff. And it provides an interesting protection so that people can have that available. And interesting, there was a lot of confusion about that in the state legislature. When this bill came up, I remember very clearly that the bill sponsor was asked by a committee member, so are we worried that someone is going to be taking this naloxone and snorting it in the hallways, during the school day? And there was some really interesting education that happened about what naloxone actually is and how it's used. So I assume this group already knows about it. There are Revive actually comes from Harm Reduction Therapeutics, which is an oxymoronic nonprofit pharmaceutical company that makes a 3 milligram naloxone product, which all research shows, especially in the 2-dose packaging, in case you need the second administration, should be more than sufficient to take care of the vast majority of overdose situations that happen. And then there's Narcan or generic 4 milligram nasal spray formulations. Those are both available over the counter. I just want to urge, while we're talking about this, caution. I know a lot of organizations and local governments have the ability to make their own decisions when it comes to what types of naloxone products they are going to purchase and distribute. There have been some manufacturers that have been promoting and pushing the use of very high dose products. I consider them very high dose products based off of evidence in the research literature. One of those is Zimhigh. That is an intramuscular auto injector that delivers the equivalent of 12 and a half full 0.4 milligram vials of naloxone in a single dose without the ability to titrate. And that's a lot. And then Kloxxado is the approximate equivalent of 10 full intramuscular vials. And you get there, I won't explain all the math, but when you have a nasal spray, it takes about twice as much in terms of milligrams as it does when you're looking at the injectable, the intramuscular liquid formulation. And that's how you end up running these calculations. Now, I'm not saying there may be no place for Kloxxado in the overdose prevention landscape. However, the research indicates that the Revive and Narcan or generic 4 milligram products should be more than sufficient for your use in the community. Nalmefene also, they recently stopped the push from the pharmaceutical company to market this heavily for overdose reversal. They realized they're kind of reached their limits there. It's known by name brand OPVEE. There's one other name brand as well. But the data indicates it's not ideal for overdose reversal because just like those high dose products, I didn't mention why they're concerning, but they can create situations where there can be more significant and even severe precipitated withdrawal symptoms by people who have overdose. And when their overdose is being reversed, well, yes, we're saving their life, and that's super important, but we're creating situations where they may be at even higher overdose risk for overdose than ever before if they are in such withdrawal pain that they are going to do just about anything to go get their next dose, or maybe they don't really trust anybody to help them next time if they were given something that made them feel that way. And nalmefene has the potential to do exactly what I just mentioned, but prolong those withdrawal effects even further. So it's something to consider when you're looking at your purchasing. This was just wanted to have this citation. There's the ability to see the bill number from 2024 at the naloxone med schools issue. Drug checking, test strips, a huge issue. So I'm really proud of this. I wrote a proposal. I'm glad to have played a role in this. I wrote a proposal and got it through the Department of Mental Health Planning and Policy Council legislative committee process, which they allow once a year, and got to use the same form State Department commissioners use to send their own proposals to the governor every year. And I proposed decriminalized drug checking equipment. My original proposal was all drug checking, so all forms of testing equipment. But the governor and the commissioner of Department of Mental Health, what was ultimately sent by the governor's office to the legislative body was focusing on synthetic opioids. So they passed a law that next year. It was a little tricky, but they got it done, that decriminalized testing and testing equipment for synthetic opioids in illegal substances. And that means fentanyl test strips became legal. There was a 3-year sunset, which means it would be automatically repealed in 3 years if there was not another bill passed. I wrote another proposal, got that through that same Planning and Policy Council process. And amazingly, that bill that came out of the governor's office ultimately passed unanimously. And so now fentanyl test strips are permanently carved into state law as exceptions to the drug paraphernalia statute. Xylazine test strips are legal for now, because if at any point xylazine is added to the list of scheduled controlled substances in Tennessee, then the second that happens, xylazine test strips would become illegal unless the drug checking law is expanded from synthetic opioids to at least include sedatives or synthetic sedatives, because that's what xylazine is categorized as. I also want to mention that checking for other types of, if you want to do checking, there's things, mass spectrometry and other ways of, taking a sample of drugs and testing to see exactly what's in it. You cannot intentionally do drug checking in Tennessee if you are intentionally testing for things other than synthetic opioids. But if you are testing for synthetic opioids, then you can do things like mass spectrometry. And so you obviously need to be very careful when you do that. You don't want to run afoul of state law, but there is potential to use mass spectrometry. And the Department of Health, in fact, is running a relatively new drug checking program and piloting that as we speak. So very cool. This is just an old slide I had, so I included it. It's got a reference to an article that came out from the original pilot data that the Department of Mental Health put out showing how fentanyl test strips were being used by those surveyed and whether they were making behavior changes. And a huge percentage of people made very positive behavior changes, everything from not using at all to using less, to making sure they had naloxone or someone with naloxone with them, not using alone. It's adjusting their dose, etc. So, I mean, obviously, we'd prefer that people not use at all, but if they're going to use, then we hope that they would use in the safest, least lethal way possible. This map is a little outdated. Again, I apologize. I was a little behind on getting to update my slides. But I put a link where you can get to the current map on the syringe services programs in Tennessee. This is under the Department of Health, and they credential community organizations that want to be considered syringe service programs and provide services to people who are actively using drugs. Everything from syringe exchange, as the name implies, to providing other supplies and wound care, things that can help that person be safer and have less chance of overdose risk. They also play a key role in informing people about and directing people to treatment. And there's a lot of great evidence that syringe services programs significantly increase the chances that someone might end up going to treatment, that they have a lot of people that they serve that do end up going to treatment. So it's really, really important to have access to these programs. I know that there's been some expansion through local health departments. I know in East Tennessee, for example, or Northeast Tennessee, they've been doing some of that. And I know the Department of Health is interested in expanding, putting these syringe service programs on site, either in parking lots or in buildings at local health departments as they're able to. So this is something they're working on, seeing how much more they can do and to make sure more communities have access. And there are certain protections that people have when you go to a syringe service program. So if you are a participant in such a program and you are caught with syringes, and you can show or identify yourself as a syringe service program participant, then you cannot be prosecuted for having drug paraphernalia, if that's part of that. Now, there is a bit of the law that is missing that doesn't cover if there's any residue, but having clean syringes, I mean, unused syringes, excuse me, those would definitely qualify as what they get protection. People get protections for if you're part of an SSP program. You're enrolled in one. You've been getting services from one. There are limitations under the law where they can be located regarding number of feet away from schools and such. And that is very important to look at. Good Samaritan law. This is something I'm very passionate about. I've been very involved in as well. I proposed another legislative proposal through that same formal process I mentioned for the test strips. And the goal was to remove the one-time overdose limit in the Good Samaritan overdose response law that was created in Tennessee in 2015. The original bill didn't have that, but an amendment basically said if the person who's overdosing has ever overdosed before, they do not get the immunity protections that are offered for simple possession of drugs, casual exchange, or possession of drug paraphernalia that others get. And there's also protections. You can't be arrested for many violations like probation violations and other kinds of things. So the law is mostly really well written, except for that one-time overdose limit in terms of protecting people who call, and especially the person overdosing, from getting in trouble if they're trying to do the right thing and save someone's life. It is very limited to that circumstance. You have to be calling for medical assistance when someone is experiencing a true overdose situation or a likely overdose situation. So it protects the person overdosing, again, only on the first time. There is a limited expansion that happened to that based off of the proposal that I wrote. It didn't get passed the way we asked. But they now allow local law enforcement and DAs to apply immunity protections at second and subsequent overdoses at their full discretion. So it totally depends on, it could be the individual officer, the local police department or chief or sheriff's department, or sheriff, or the local district attorney. And so far, I have not heard of any jurisdiction that has put in writing that they will not prosecute on second or subsequent overdoses, though we know there are some, especially in the major metro areas, some of them at least, that are not prosecuting in these situations and not arresting people. Just wanted to make sure everybody understands the limitations here. And you'll understand this drug-induced homicide law here because it really plays a key role in whether the person calling or otherwise seeking medical assistance is fully protected under this law and can take advantage of those immunity protections. Last year, something else I'm really proud of, this was an idea that came out of a meeting I happened to be in and led where we were kind of reviewing what we were expecting for the legislative session. Realized we were missing alcohol-related immunity protections in our state law. Put the best proposal we could together, and unanimously it passed last year, and now Tennessee has added on lots of great immunity protections for situations where young people under 21 use alcohol to the point that they need medical attention. It protects them. It protects the people who are calling, even adults who may have been the ones to provide alcohol to them. And again, in very limited fashion, and meant to help save lives and encourage people to call for help instead of ignoring, kicking someone to the curb, etc. And this is especially important, say, on college campuses, for example. And so we're really excited about, please spread the word that that exists. It would tagged on to the original Good Samaritan law applied to drugs. Drug-induced homicide laws passed in the last few years have made it so that if you provide a controlled substance to someone and they die, and it doesn't necessarily mean sell to them, distribute, it could be literally if you hand it to them, you use with them, but you were the one who supplied it, you can be charged. And actually, in fact, the law calls for you must be charged with second-degree murder or a newer drug charge that carries the equivalent of second-degree murder. And my understanding was that the district attorney's conference asked for that newer drug charge because not all juries were willing to convict on a true second-degree murder charge, knowing that normally that otherwise involves intent being required. And this is not something where intent can typically or easily be proven. So now there is a new drug charge that carries the same sentence. So how does this apply to the Good Samaritan law? If you are a person in good faith, wanting to do everything possible to save a friend or loved one's life who is overdosing and potentially at risk of dying in a house, on the street, wherever it may be, and you call 911, you administer naloxone, you follow the instructions of the 911 operator, give rescue breathing, do the whole 9 yards, do everything possible to try to save this person's life. Never intended. You happen to be the one that got the drugs from somebody and you used with a friend, and you shared a pipe or a needle or whatever it may have been, and they die, you can absolutely be charged with second-degree murder. So there's no immunity protection in that situation for someone seeking help for somebody if that person ultimately dies, just no matter how they go about the situation. So I wanted to mention that key hole in the Good Samaritan law that keeps it from being as effective in convincing people to feel comfortable in calling 911 without fear of serious consequences. And in many areas of the state, this is being harshly prosecuted. This is just a quote I put in here. I'll let you read it and have it for later. This is from the bill sponsor on the alcohol-related Good Samaritan law from last year, and her thoughts on its impact and its ability to help save lives. I also just wanted to mention, because I mentioned the one-time overdose limit, there is a bill currently filed. I'm not sure how likely it is to move or pass. Law enforcement currently is opposed to removing the one-time overdose limit entirely, but I at least wanted to reference this so you knew what it was and that it is currently in the General Assembly. Okay, so this is where I ran out of time. I apologize. There are lots of criminal penalties, and they vary often by type of drug or drug class. So there's different criminal penalties, ranging from misdemeanors to felonies, depending on whether you are found with just possession, and the amounts can vary based on the type of substance involved, possession of drugs, the intoxication with certain drugs, distribution, manufacture, or sale. And those penalties can go all the way from mid-level misdemeanors to the severest felonies imaginable. I know at least Class B, potentially Class A felonies. We already talked about second-degree murder charges. So there are major penalties, and Tennessee has some of the strongest, some may say harshest criminal penalties for drug use or drug possession and drug distribution of any state in the country. There are also policies involving recovery courts and the ability for courts to help people navigate out of the system when they get into it, the judicial system, which is great to provide all sorts of services to people and not always have them go through the typical experience someone would have in jail, where oftentimes true rehabilitative services and evidence-based treatment may not easily or readily be available, especially not in all county jails. There is not enough medication for opioid use disorder treatment available in county jails across the state. Far fewer offer it than don't. Recovery housing regulation. There has been an increasing interest in the General Assembly in regulating recovery housing, and a lot of this stems from NIMBYism. Not in my backyard, for those who don't know what that means. And just not liking that there are homes where lots of people who have used drugs are residing. There may be real concerns from incidents that may happen in some situations, but largely what I've observed is fear and concern over the idea of people who use drugs being in someone's backyard or their community. So there were some bills that passed last year that one created some standards that any regulator in the state of recovery housing, and there really isn't a true regulator. There are some credentialing bodies that voluntarily credential recovery housing or sober living facilities, and they have now have standards that they must hold their credentialed members to if they want to be credentialed. So that's new. There was also a bill that created a pilot program structure, if they wanted to use it, in Hamilton County that frankly is kind of ugly and does not really it's just looking very down on recovery housing and the people who use it and really wanting to restrict it. There was a new bill I saw that was just filed that is looking to expand that to Putnam County, just as a heads up. So I don't believe a pilot has started at Hamilton County, but the framework has been laid out. Also, and I'm not sure how much time, Sharina, how much time do I have? I want to make sure I stick to it.
Maybe another 7 minutes if that's good.
Okay, perfect. I will speed through these slides, but pre-arrest diversion and deflection, I think, is very important in this space. And that's where we're looking at collaborations with law enforcement and also doing law enforcement differently than we have in the past. Again, I'm going to speed through some of this, but deflection is different than diversion. It's a type of diversion. But we talked about recovery courts. That's similar in a way to pretrial diversion. That's after someone already gets into the criminal justice system. Deflection is intentionally trying to keep people from ever getting into it or from getting back into it, and then really helping to not just point, but hand them off in the right direction to appropriate services and supports. So here I've just got some differences between deflection and diversion, which you'll have the ability to look at later. And I think it is kind of interesting to look at why this is so important. These stats are a few years old now. I just want to acknowledge I have not updated them. But the ratios should be holding that there are a lot more people that can be impacted by deflection programs than waiting till true traditional diversion until they're already in the criminal justice system. So why prioritize it? We don't want unnecessary arrest and incarceration. We want to prevent unnecessary healthcare visits, emergency rooms, hospitalization. We want the justice system to be able to do its job. We want law enforcement to be able its job and go after true bad guys who are a risk to public safety and make sure people who need help get the help and support that they need. It helps save lives. It's cost effective, has consistently positive outcomes. It's possible that I've yet to see a deflection program that has not shown at least some sort of positive outcome, some more than others. And it helps build community trust and trust with people who use drugs as well. There's three main types. Law enforcement can do it themselves. You can have co-responders that go out with law enforcement, or you can have another non-law enforcement entity go out instead of law enforcement. Some of this involves mental health too, but a lot of these programs look at both mental health and substance use. CIT, well known, developed in Memphis. That's a law enforcement only approach where they have specialized training, specialized dispatch protocols, a coordinator, and so forth to make sure when people have mental health issues, especially sometimes addiction issues, that they pair a specially trained officer and just instead of a normal law enforcement approach. Co-response, you guys in Knoxville are familiar for sure with all of these, at least the first two here. That's where you send out, your program with someone from McNabb Center along with law enforcement on certain calls. And then community responders. I know of at least two communities doing this in the state. We've got Nashville and Cookeville that send non-law enforcement response teams made up of EMS or medics and mental health professionals to engage people when it is safe to do so, and there's clear indicators of mental health or addiction issues. And then there are substance use specific deflection programs. There are overdose response teams, quick response teams. Sometimes these are just law enforcement based. Sometimes they involve community partners. Sometimes it's just the community partners that are doing this with referrals from law enforcement. And then there's things like just law enforcement actively, proactively distributing naloxone in areas or to people that they think might benefit from them, helping them get connected to treatment and so forth. So very important. And deflection programs are only as good as if you have the deflect to what answered. Can they go somewhere? For mental health issues, 24/7 crisis walk-in centers, or the empath unit that's now available in your community. What basic needs do they need? Can they benefit from outpatient services? Will that take care of it? Do they need medical care? Could they benefit from buprenorphine treatment or methadone treatment? Do they need peer support? Can a recovery navigator help it? Might some respite care be helpful? There's all different things, but you have to make sure you have the things that people actually want to access and can be effective in order for deflection to work. And also, really important, it needs to be voluntary and least restrictive whenever possible. Here's some federal policies that play into people with substance use and people and the general substance use disorder landscape. Americans with Disabilities Act applies to all sorts of public accommodations, protects both people with mental health and substance use disorder in addition to other disability type issues. There is a clear exception for substance use. If someone is actively using illegal drugs, they do not, at that point in time, qualify for ADA protections. But as soon as they are no longer actively using illegal drugs, if they've ever had what could qualify as a substance use disorder before, whether they've been diagnosed or not, they are absolutely protected by the ADA. Fair Housing Act protects those same populations from housing discrimination. It applies to homeless shelters, recovery housing, and residential treatment. Workplace and professional licensure boards. Discrimination can and has occurred against professionals seeking licensure. In fact, there was a case in your area in Knoxville with a lawyer who was not given his law license simply because he had been prescribed buprenorphine for a significant amount of time, and he preferred to keep taking it and based on recommendations from a doctor instead of stopping. And this led to actually intervention by the federal government and a very strong worded letter to the Board of Legal Examiners and Lawyers Assistance Program by the Assistant U.S. Attorney's Office in the Middle District of, I think it was the Middle District of Tennessee. So very important to understand that, the policies, big P or little p at those levels can absolutely impact people who use drugs. And that may or may not be related to why there's a huge need for legal advocacy services in Tennessee. We just have hardly any of that. We do have Disability Rights Tennessee. They're a great organization, but they don't specialize in particular in people with substance use disorder, and they don't have a lot of bandwidth for that. So who's available to provide basic education about people's legal rights, help them file complaints to the right folks, to the right regulators, and file lawsuits when needed? There's really not a lot of infrastructure or resources for that in Tennessee, and it's something that is missing. Just because we're talking about policy, I'd be remiss to not mention advocacy and its importance and all the different types of roles people can play. I love advocacy. I get involved in it strategically in many different ways. If anybody's ever interested, especially in terms of advocating for a specific program at the state level or in your community, or if you want to get involved in legislative advocacy or learn more, feel free to reach out. My cell phone was on the very first slide, which you'll get a copy of this again. But there's lots of different ways you can get involved in advocacy. Also wanted to mention, for those not aware, please, I really want more people to come to this because there is amazing educational content being delivered twice a month, totally free. There's continuing education, like CEUs provided by the Department of Health through their Harm Reduction Project Echo series. I'm a little biased because I am the policy and advocacy subject matter expert for that Echo, but I can tell you the speakers have been phenomenal. And there's a lot of great things people can learn here. It's people both in and out of Tennessee coming in as experts, sharing about all sorts of things. There's 2 different tracks, but lots to be learned here. And with that, I'm done. Sorry, I know I've took quite a while, but if there's any questions, I'm happy to answer for as much time as you have left. Thank you.
Thank you very much, Elliot, and no worries on the time. I do have several questions that we've collected during registration and then as the presentation has gone on. So the first question I'll kick off to you is, how does our state's approach to substance use policy compare to neighboring or similar states?
Well, in the trick is in a lot of our policies are similar, and then some of them are different. And there's often trends, frankly, along partisan lines where you have, Republican meaning red, Democrat being blue. When you have mostly red states, you tend to see harsher policies. When I say harsher, just more severe criminal penalties in terms of possession, things like I mentioned about drug-induced homicide laws, not as much willingness to allow, evidence-based drug checking methods and so forth. It depends. Texas, I actually have not gotten an update on if they passed test strips. I know they've been working at it for a number of years and struggled, fentanyl test strips. But, some states, they've really struggled to get these things done. Some states, like West Virginia, realized their fentanyl test strips law was way too narrow. And they had to go back and look at broadening it to allow a lot of other types of drug checking. And even the Republican leadership there started to realize it. So even though there have been some partisan leans to in certain ways here, we have seen a lot of common ground in a lot of states. Most, if not all states have good Samaritan laws, but the degree to which they protect individuals and actually enable people to call 911 without fear of getting arrested is a whole nother issue. In terms of the treatment landscape, the way things are funded, the way policies are set, that pretty much is similar across most states. Sometimes there's distribution of authority to local governments to administer some of the mental health and addiction program that the state administers here in Tennessee. So it's hard to answer because it varies based on the type of policy. So we do have some of these most severe criminal penalties in terms of enforcement for illegal drug possession and use. But we also, at the same time, do have some very positive policies. Like, again, that Good Samaritan law is almost one of the best now with the alcohol community protections. If only we get rid of the one-time overdose limit so that people can be educated about this without all the caveats. So I hope that's in some way answering it, but I'm happy to get more specific if helpful.
Yes, that was great. Thank you. All right. And then the next question is, so for smaller nonprofit organizations that seem to be mainly concerned about how stretched thin they are, is there any kind of area of policy you recommend they make sure they pay attention to?
Well, the first thing is, if you're stretched thin, that probably means you could use more resources. So I would certainly want to pay attention to any policies that may impact your current or future ability to access the same or additional resources that you're getting now. So just as an example, this was reversed, but there were a lot of folks really freaking out just in the last week or so when the White House announced canceling nearly $2 billion in SAMHSA grants all over the country. That was reversed about 24 hours later. But things like that can be huge. So both in terms of watching and paying attention, but you can look at funding priorities. So what they're saying before things become policies, then when their executive orders are written, even those if that's not necessarily law, we know that they have now said that at the White House level that they don't like the term harm reduction, and they largely blame harm reduction for contributing to overdoses worsening, even though I don't think that is backed by research. But that's something they have said and can be an indicator for what they may or may not be willing to fund going forward, right? And they've also had an executive order on homelessness that talked about some pretty severe policies regarding forced treatment for individuals and so forth. And I've even heard rumor on pretty good authority that we're expecting to see a bill filed in Tennessee shortly that may require just that, some sort of forced or coerced treatment for people who are homeless. And I'm expecting that may cover substance use, but it's not clear yet. So it depends on what you're looking at. But I think from the perspective of if you're stretched thin, you want to pay attention to the things, policies that impact your ability to keep doing your work and to make sure you don't get in trouble. So if you're doing any kind of harm reduction work, you want to make sure you know all the rules about naloxone and what you're allowed to give out and not allowed to give out in terms of test strips and drug checking and those kinds of things. Because if you get in trouble or sued, that could be very much devastating to your ability to exist and keep helping your community.
Great, thank you. All right. The next question is a bit more of a specific policy type specific one. Are there any policies that you know of that are coming up to increase access to care for justice involved individuals post-release, especially those who don't have reliable transportation and or live in an area with limited public transit?
Great question. There is a policy that exists at the federal level that right now is not being taken advantage of at the state level. And I want people to be aware of this. So, within the past few years, Centers for Medicaid and Medicare Services at the federal level, they basically put out an announcement that they are allowing states to either request waiver authority or demonstration project authority or to expand their current demonstration project authority to provide at least 30, but potentially up to 90 days of Medicaid coverage to people who are in jails and prisons before they are released, to provide for sure evidence-based addiction treatment, but also mental health treatment, certain amount of medication to last them for an amount of time after they leave, supply, and then also to help with that transition to the community. And just having that coverage instated before that person leaves on its own is very, very important for a lot of cases, because that can be a big barrier when people leave carceral settings. TennCare has been asked about this and so far has not expressed interest in pursuing that authority. I have talked to the sheriffs about it, or at least the head of the Sheriff's Association, and they think that kind of thing would be great. I'm not speaking for them. That was a casual conversation, so please understand that. But I think there would be a lot of interest in this. Now, of course, the Medicaid population in carceral settings is only a certain percentage based on what I talked about at the very beginning, that not being a poor adult doesn't just qualify you, but there is a significant number of people. And if we can start getting funding that will help in a big way for this population, that would be great. So yes, that requires some state funding in combination with federal funding, but the federal government picks up a big share of that. So if you're interested in that, that's a potential area for expertise, for learning more about and getting more involved in, potentially even expressing your thoughts to TennCare or your state legislators about how important that you think that may be, if you wish to. I have not heard a ton more about what they're looking at. The things that I have confirmed on this side that are or believe are coming up are there's going to be a bill to ban kratom completely. It's been filed already. Criminalize it on both the sale, manufacture, and also the possession side, with very serious criminal charges involved. Also requires, interestingly, testing for kratom anytime the physician would be testing for other drugs related to an overdose. So we'll see how that plays out. There's a bill coming, I don't know if it's been filed yet, regarding allowing research for the use of Ibogaine for the treatment of PTSD and also opioid use disorder. So that is something that I've heard is coming. And I mentioned that other bill that we know of regarding the people who are unhoused and potentially forced treatment, involuntary treatment for that population. There are also some bills that are already there about fentanyl and criminal penalties that did not all the way pass. I expect some of those bills to continue and recovery housing regulation to continue. I'm sure there will be a lot of other stuff. We expect a bill that is going to be looking at allowing nurse practitioners and physician's assistants to prescribe and administer that mono product that I mentioned, if it's an injectable done at a facility. Again, these are just some examples, but we'll soon, by the end of the month, know the full slate of what we're expecting. It's possible I haven't heard of something, but that's what I know so far.
Fantastic. Thank you. Admittedly, I thought your response was going to be unfortunately no, so it's great to hear that there is some room there. Glad to hear it. All right. A few more questions. So, what is your perception of the confidential phone support programs for someone using drugs while alone?
Well, that's an interesting question, and I don't think I prepared enough for that particular one. I wish I had it in advance so I could, make sure to just do a little more research. I wouldn't say I'm the leading expert on that. So, and I don't know, do we have those programs available in Tennessee? Can someone educate me on that? I'm not sure where we have those programs in Tennessee.
We do have two that I know of, not necessarily strictly in Tennessee. Like I think Never Use Alone. Someone can correct me if I'm wrong. I think they're national, not
They are.
specifically, yeah, Tennessee. And then there is another one. I know that it was shared with me recently. They're smaller, but they are also, again, same format, phone-based. You call in and then they'll monitor.
I just wasn't sure if we had any in Tennessee. So if they're all right, please, if anybody feels just like sharing with me afterwards, I would really be grateful. But my general thoughts on that as a concept based on the research evidence, is that we certainly would much rather have somebody, if they're going to use drugs alone, but instead they might talk to somebody else who could potentially call for help in the event of an overdose situation. We'd rather them have a chance of living in that situation than overdose and die without anybody knowing. We certainly don't want to unintentionally encourage drug use, but my understanding of the evidence is that such programs do not do that.
All right, thank you. And then the next question is, this one is going back to the Good Samaritan Law section of your presentation. The limitation to the Good Samaritan Law seems to be a major deterrent to and defeat its purpose. What are the chances of changing that?
Excellent question. I'm squarely in the middle of all that stuff. I've testified to the General Assembly on this issue before, when they took a different approach. It was under something called Brittany's Law, where they were trying to make it a criminal penalty if you did not call 911 when you thought someone was overdosing. And fortunately, that bill did not move forward. It just wasn't evidence-based and could have caused some problems. Um, the chances are challenging, but doable. Again, I mentioned some of the progress we've made, at least baby steps. We got the alcohol-related immunity protections in there, to open that up to new population of individuals. And then we also got at least some discretion. So no longer are local law enforcement ignoring and flaunting the law if they don't arrest or prosecute for second and subsequent overdoses, but they have the authority under the law to do that, to not prosecute or arrest. Law enforcement is very strongly opposed to the idea of completely removing the one-time overdose limit. And I was told that by one of their association lobbyists that they believe that people are best served by going to jail and hitting rock bottom, and that arresting them or not just going out and responding and not arresting them over and over doesn't help. And I wish the evidence supported their theory. It just doesn't. And this is the biggest flaw with our Good Samaritan law is that we can't easily communicate that it exists. Most people don't know about the true nature of it and what it does. And the one-time overdose limit and the implications from the drug-induced homicide laws definitely need to be addressed. I think it will be sooner that the one-time overdose limit can be addressed, whether it's this session or within the next few years. I think it's doable. I think there's a lot of interest. I just think it's going to take some groundwork. But that's doable. But the idea of putting out the immunity protection that exempts people from the drug-induced homicide part, I'm afraid that might be a tougher hill to climb, yet still an extremely important one. But we need all the advocacy help we can get on that.
Agreed. Yes. And then similar to that question, does the Behavioral Health Foundation or perhaps someone else you know of have a flyer or handout that summarizes key information about the Good Samaritan law?
Yeah, absolutely. I have some bill sheets that I have easily available that I can provide, both talking about the one-time overdose limit removal bill and the alcohol-related immunity bill. And then we have a one-pager we worked with UT Knoxville on, that I know they were developing and distributing. So we've got some of that. And I also have some deeper dive, like things we use with legislative attorneys and such, that really dives into some of the changes, exactly what's covered and all that, that I'm happy to share. So If folks want to reach out to me and kind of let me know what level of information they like, I'd be happy to provide something that best fits what they need. So feel free to reach out. And I'll put my cell phone number, which is the best way to reach me in general. And please don't be afraid to call or text, and also my email in the chat.
Fantastic. Thank you. And then Elliot, would you be okay with, since there are several people who registered, but they knew they wouldn't be able to attend, would it be all right if I share that in the follow-up email?
Oh, absolutely. I put this in the title slide of the presentation. I really do. This is why the Behavioral Health Foundation is here. We're not trying to be the drivers of all legislative policy change. We are trying to help collect, develop, and provide the ideas, information, and evidence to all of you all out in the community to help move the needle forward on these issues and do your job better. So we appreciate very much all of what you all do. And thanks for letting me be here today. Always happy to come back if you need me and reach out anytime.
Wonderful. And we were very glad to have you. So thank you very much, Elliot, for your time and your expertise that you're sharing with us or that you did share with us this afternoon. And thank you, everyone, to those of you who were able to join us for today's session, as well as those of you who will join us retroactively when you watch the recording. Before we conclude, I do want to remind you that there will be a brief questionnaire following the webinar. It should pop up in your browser, and we do genuinely value your thoughts. Your responses will help shape future sessions of this series, and we would appreciate you taking a few minutes of your time to share your thoughts with us. And then, of course, we also want to mention when our next event is, and it will be on April 16th from 1 to 2:30. It will be a hybrid session, so if you're not able to join us locally in person, you can hop on a Zoom and we'll see you there. The presentation will be Understanding CBD versus THC Regulations, and that will feature Stephanie Armbruster-Strutner, who is the CEO of the Prevention Alliance of Tennessee. She'll walk through key regulatory distinctions and considerations related to CBD and THC. And then information on that webinar, along with access to today's recording, will be shared in, again, the email address that you used to register. So that being said, on behalf of All for Knox, thank you all for joining this session of our Substance Misuse Prevention and Education Speaker Series. This concludes our webinar, and we appreciate your participation. We look forward to seeing you and continuing the conversation in future sessions. Take care, everyone.